sense, and in fact, the chief executive officers almost believe this IT stuff is just magical. You just flip a switch and it just happens. And so I actually asked them this question. I said, well, I'm happy to do it, but I need a plan. And that is, who are you going to connect with what for what reason? And they said, well, we can't tell you, because the marketplace is changing so fast. You have to be agile enough so that when I call you tomorrow and say we need to start doing summaries with organization A, B, or C, you can just do it. And the only way we can achieve that level of agility is by having a health information exchange that effectively does this as a community-based solution instead of a point-to-point solution. Because those point-to-point solutions are they're just time sinks, they're certainly challenging to support and maintain, and from a legal point of view, they're probably even less secure because they're one-offs that you may very well develop security problems with since you're doing each one as an individual project. So I'd love your comments as you think about healthcare information exchange in Chicago. Do you feel that you've built the trust in the community, that you've overcome the value proposition question with the CFO, and that your C-suite, of which you're a member, feels a sense of urgency to do this, and that what you've done thus far seems foundational for the future? So comments, dialogue, discussion. I've stunned everybody. Yes?
I'm Dave Prince. I'm with two hospital system in the western suburbs, and this is the kind of thing, what we're doing now with our health information exchange is something that Chicago tried to do about 15 years ago. We were before the web.
Yep.
And I think now we've got the tool set to make it happen. And I do believe that because of MCHC and the involvement of that team that's existed here for decades, we have the trust, and I think we've put together, I know we put together a very interesting model for return on investment which we applied to our own institution, and I think we've got buy-in quite well now. The fear that I have is the unknown, and you commented on it in a number of cases about the legal implications and the delayed decision-making surrounding the legal issues that may cause us greater difficulty in the future. I'd love it if you would comment a little bit more about those issues and what CMS is or is not doing to help in that regard.
Sure. So a couple of thoughts is that certainly we have found that putting together a community of people like yourselves to come up with policy is the most protective thing you can do from a legal standpoint. Because if you're doing the same thing across an entire region, pretty hard to argue that what you've done is aberrant. I mean, you're now meeting the community standard for whatever you decide is consent and disclosure and auditing and all the rest. Certainly the legal and policy work groups that work in Washington, the Privacy Tiger team, they're trying to come up with more guidance, like what is meaningful consent, and how, as you, as an entity, do consent. You could have many models, opt-in, opt-out, some things that are a bit more esoteric than that. And so CMS will effectively give us frameworks by which you can then locally develop with a community the standard for your region. There certainly is going to be additional work as we begin our stage 3 discussions, which actually start in the next 60 days or so, to make sure that as you have gaps, whether they're policy or technology, that we close those gaps with that final regulation that's going to come out more in the 2014-15 timeframe. But in the short term, do it at a community level. Get everybody on the same page and you'll be protected.
Have you been able, one of the issues in Illinois is the laws around what can and cannot be disclosed in behavioral health.
Yep.
Have you been able to bring the behavioral health community into this effort to get their support? Because that's a barrier at this point. The risks involved in the example you gave an HIV example, just the same
Sure.
thing, is a considerable risk. Has there been a way to get past that in Massachusetts?
There is, and so again, this may not apply to Chicago, but want to be careful. We, as a state, decided that we would do institution-level opt-in consent to disclose. And what that basically means, we have been able to get 90+% opt-in consent. We did it as a pilot in 3 cities, and we went to the adults, educated them, and said, oh, we've got your record, including behavioral health records. It's up to you. Do you agree to opt in to share? And by the way, that's revocable at any time, but once you've opted in, it's a one-time event, and so data will be shared for care coordination whenever necessary with whatever providers require it. And the behavioral health community said, as long as there is institution-level opt-in consent, we're okay. So I opt in to share my Beth Israel Deaconess data, but not my McLean Hospital data, which is a psychiatric hospital. I've never been there, really. But because that way, in a sense, the patient is in control of what gets disclosed. And they were happy with that. Surprisingly, I mean, again, we have found that in the adult population that we've consented, there's a vast amount of opt-in for sharing of mental health information. And from an emergency physician standpoint, recognize that drugs used to treat mental health issues are those that have more drug-drug interactions and side effects than any other. So the last thing that we would want is to send people to emergency departments with incomplete medication lists. They're on MAO inhibitors and I give them nitrates, or whatever example you want to pick. We'll do more harm. So we did engage them and found a policy that worked.
In the example you offered, there have been challenges in the case of a patient who may have been to McLean, who was also a Deaconess, and the compulsive primary care doctor, Beth Israel, has got his or her record up to date and complete.
Yes.
And you as an organization have opted to share, and the patient has authorized that, but not the McLean information. How do you deal with that circumstance? Well,
So we have in our this is an EHR specific issue. So we have something in our EHR called a locked note that is not shared. And so it is then up to the clinician to make the assessment, and it is typically used by the mental health folks to say, oh, I have received this information, I am locking it, so it's available for internal use, but it is not shared.
but then it gets more granular than that, as you know.
Right.
Doesn't take too much to figure out from the med list and the encounter list about what's going on. So those issues are not quite as simple to solve as...
Well, that's true. So it's I'll add more complexity for you. Remember, Massachusetts has some wacky laws.
We do too here.
Yeah. Okay, so here's a wacky law you'll appreciate. So 25 years ago, a wonderful organization called the Harvard Community Health Plan decided that it would build an electronic health record. This is one of those, ran on a toaster, had 2K of RAM, that sort of thing. And it included mental health data. And it turns out that Harvard Community Health Plan not only was an insurer, but it also was an agent for several employers who were self-insured. And it said, have we got some great data for you from our new electronic health record? And all the mental health data went to the employers. And so these 25 years ago, the state government said, oh my God, this can never happen again. We will make it illegal for payers to share mental health data, even with patient consent, from electronic health records to anyone. And so here we have this very funny law. If I go to CVS or Walgreens, and I pick up my AZT, my OxyContin, and my Prozac, it turns out SureScripts has a comprehensive record of everything that I did at Walgreens or CVS. If Blue Cross reimburses those, we have what is called a restricted drug list. And so we are not allowed to share the payer-based data for mental health, substance abuse, or HIV. It has to be filtered out through the restricted drug list first. But if CVS or Walgreens reports it, no problem. And so you're right. I mean, you do your best. Restricted drug list on the meds, locked notes on the text, and patient consent wherever possible.
The issue really comes down to, rather than restricting the information, restricting the access, appropriate access for the ER doc is appropriate.
Right.
Inappropriate access by the employer or the other potential nefarious user is where the detention needs to be addressed.
And then, of course, you need good policies that will protect the integrity of the network. So there'll be, conceivably, whether that's a civil penalty, whether they, in Beth Israel Deaconess, our policies would suggest inappropriate access, social engineering kinds of access, termination. If you're the chief of medicine, you're just as likely to be fired as a secretary if you looked up somebody inappropriately. And then we do random audits and a lot of decision support tools that actually look who is looking at what in an attempt to discover whether that's an appropriate effect. Very hard to mine audit logs and detect. It's easy, for example, if somebody looks up 50 patients in a row and they normally look up 10. Or if Joe Famous shows up at the hospital and suddenly, instead of getting 10 lookups, there are 100. It's really hard. I'll give you a case example. Ben Affleck turns out to come to one of our hospitals. Ben Affleck has been in the emergency department. I am an emergency physician. I look up Ben Affleck's record. Is that legit? Well, emergency room, emergency doc, seemed reasonable. I've never treated Ben Affleck. So you're correct. These get to be hard.
So it gets to be more hard when you globalize this and move it out to an HIE status. It's challenging enough in a relatively controlled environment. But I don't know that Elgin is not looking at somebody who's in my environment that they've never seen, maybe by accident, or maybe with nefarious intent.
And so our feeling has been this: having done health information exchange for 15 years through NEHEN, and having done electronic health records for nearly 30 years, we've said, perfection is the enemy of the good, and would we rather give clinicians access to the data that is appropriate at the point of care and fire them and sanction them if they misuse that data, as opposed to try to build such technical controls that we deny access to the data when it's appropriate. So far that balance has been
We
okay.
believe in the access and execute.
Exactly. So access and execute, that works. Yes.
So switching from trust to the use of the data.
Yes.
You talked about something which I think is actually a fundamental assumption. I'd like to get a feel of how true that assumption was. So the assumption is that you can go from the data reported as part of providing care to generating quality measures that then get automatically reported to the agencies that want to see it.
Correct.
And I've heard a lot of sort of sideways discussions among providers that that's a bad assumption. That in fact the current model is abstract data, and that if you don't have someone live, at least at the beginning for a serious period of time, validating that the automated extracts are working, that we're in a paradigm shift and you get a lot of bad data that's turned into quality measures that then affect people's incomes. And 2 years from now, there will be this huge meltdown as people realize that lots of bad information has been spread out.
So this is a key point. So garbage in, garbage out. Your quality metrics are only as good as the data that's initially provided. So we've had to approach this in several ways. So first, in our EHRs, we've give you 2 examples. We built, oddly enough, our own EHR at Beth Israel Deaconess. It's a Boston thing. But we also use eClinicalWorks for our 1,500 of our community docs. What we created was a template-based model office where the vocabularies are specified for every one of our docs in an identical fashion, so that medications are in RxNorm, problems are in SNOMED, so we're actually forcing up front.
Forcing standard vocabulary.
Exactly. So that, to the extent that we could, not every EHR does this, but we actually chose with eClinicalWorks to build a cloud-based hosting center ourselves and offer through the cloud a completely, although there is customization in Office workflow, at least the vocabularies, the dictionaries, the code sets, they're all the same. And you are quite correct that quality metrics are sometimes very challenging to compute. The number of exclusionary criteria can make these things overly complex. So we did several audits to prove that these were sort of good enough. We did a manual chart abstraction as compared to the electronic transactions. But then MITRE Corporation has developed something called Pop Health. Anyone go to HIMSS? So this is a, I guess this is a demonstration at HIMSS. where they took 2 million Beth Israel Deaconess records and computed all the meaningful use measures and quality measures for PQRS based on the raw data from Beth Israel Deaconess, and we compared that to the metrics that we did through our HIE, and we found it was like 99%. I mean, it was very, very close. So in effect, you control the data up front, and then you audit the back end to prove that it's good enough. But there is no question that healthcare data in historical systems is generally very bad, and that administrative data for quality measures generally useless. Yes.
A question, going back to Maureen Kelly,
Yes.
to the slide from that, okay?
Yeah.
Whatever happened, and what's your opinion on why we did not come up with a unique health identifier?
Okay. Well, remember Bill Clinton? Yeah. Bill Clinton signed an executive order prohibiting HHS from even discussing a national healthcare identifier for reasons of privacy concern. So there's that executive order that's been renewed ever since Bill Clinton in the budgetary process, so HHS can't even talk about it. The issue, of course, is some believe that, oh, if I have a national healthcare identifier, you'll link it to my mortgage records, my employment records, my driver's license, my privacy will be breached. So the best thinking right now is an opt-in voluntary identifier that can be used for coordination of care. If you have one, great. Maureen Kelly can be disambiguated. If you don't have one, probabilistic, name, gender, date of birth, zip, the usual match. And that way, it's something that HHS doesn't have to deal with. It's not something we force on the patients, and many people will think it is a value add. As we issue direct addresses, your direct address might actually be a healthcare identifier for you, for example. And so that's the best we can really do on a regional basis for now, because the feds can't even talk about it. Alas. Yes.
John, Ralph Wakerley, consultant who's been helping here with the project. My question is regarding HIE strategy for a big system like Beth Israel, and we have some like that here in Chicago. Enterprise level approach to this, proprietary versus go through something like a NEHEN or here in a shared network in Chicago.
Sure.
You made some great comments that interested me, like data is no longer an asset. You've got 25% leakage of patients. What's the rationale, and can you comment on, you guys as a model maybe for some of our big health systems, what's the strategy of for which users and which use cases do I invest, or do you invest in that technology directly on a proprietary basis versus where do you rely on a shared HIE model?
Sure. So this is an excellent question, because as you pointed out, life is never so easy. And there are some data sharing activities that I do that are actually outside the HIE. I mean, I hate to admit it, but it's true. So it turns out my friends at the CDC have invented something called BioSense. And BioSense is syndromic surveillance at a national level. And so we have built, for BioSense 1, we were the first hospital to connect to that. Now BioSense 2, we're going through the Amazon cloud of all weird things to do for syndromic surveillance. The CDC has licensed private space for every state on the Amazon cloud. And so in that respect, it was either a project we felt was important for the public health, it was an investigative potential project, and the HIE, I mean, it's got enough on its plate. I mean, working with the CDC may not be your highest priority for the moment. Another example, I didn't mention the word clinical trials or clinical research today. And it turns out that actually that's a fabulous use case for the data once you have it aggregated, but very controversial. Who gets access to the data for what purpose? And of course, if you start doing clinical trials, people worry that Pfizer is going to be mining your data and other bad stuff. So Harvard, turns out, has 17 hospitals, most of which hate each other, and they, but through the Clinical Translational Science Awards, I don't know if any of you are CTSA participants, it was determined that data sharing for clinical trials and clinical research was a very important thing to do outside of the HIE. So we used a technology called I2B2 that we created to enable the data mining in a de-identified fashion of all the data across the 17 Harvard hospitals. Example, I have this theory that people with blonde hair are less likely to have diabetes. And why would I have such a theory like that? Oh, it's because Scandinavians don't have as much diabetes as other people, so maybe it's true. Who knows? But to answer such a question across 5 million lives, IRB approval, data, oh my God, it'll take 2 years, right? Today, I can answer that question in less than 30 seconds. Because we have 5 million lives across 17 hospitals that have it's a server that sits on the node of each of the hospital networks that's capable of receiving arbitrary Boolean queries. And so you could say, from 20,000 medical concepts, here's a med, here's a problem, here's a hair color, here's an age, and it returns things like 27. Right? It returns a number. It doesn't return an address or any HIPAA-restricted information. So the IRB said, no problem. Don't need IRB approval to do healthcare information exchange for clinical trials and clinical research, where all you're returning is aggregate population counts. So the use cases that we went through as a community with care coordination and public health and quality and all the rest, the HIE said, yeah, that's really sensible. For these that are more tangential, we often end up doing the point-to-point ourselves.
What about care coordination among physicians you own? You talked about you've got some where you have affiliates, certain relationships, but many you own those docs.
Sure. So also recognize that the single HIE is really not a centralized single HIE. It's a hub and spoke model, as we talked about. So sometimes I build aggregation points among doctors that are the point that they plug into the HIE. So that is, in my own doctors, we have eClinicalWorks, as I mentioned. eClinicalWorks is a product called EHX, and EHX is used to share data doctor to doctor, and then EHX connects to the HIE. So another way to think about this, there are 20,000 physicians in Massachusetts, of which 10,000 are actively practicing. Do we expect 10,000 HIE connections? No. What you expect is that there'll be some sub-networks, some own doctors sharing data amongst themselves, so maybe there's going to be more like 500 connections to the HIE. So having a proprietary closed healthcare information exchange for your IDN is fine. It just then connect the IDN so it can connect to every other organization in the region.
Thank you.
Yes?
So you mentioned SureScripts and CVS in your answer to an earlier question, and looking at your slide that describes the Massachusetts HIE architecture, I didn't see the CVSs and the SureScripts shown. I'm wondering what your thinking is about where those entities play into a regional network.
Sure. So Massachusetts is the #1 e-prescriber in the country and has been for the last 4 years. We have 97% of our pharmacies connected, and we have about a 65% e-prescribing rate of non-narcotic meds. So the reason that I didn't even show the SureScripts network is it just sort of is. It didn't require the healthcare information exchange to enable it. And so our only exception to that rule is Harvard Pilgrim, who I've mentioned more than once, doesn't like CVS, doesn't like SureScripts because they charge transaction fees. So our HIE, oddly enough, does provide e-prescribing services for Harvard Pilgrim. So you can connect to SureScripts or you can connect to the HIE to do that function. But sure, having a nationwide health information services provider like SureScripts for some functions is complementary and fine. It doesn't, and it's not a business you probably want to be in, routing prescriptions between providers and pharmacies.
But when Walgreens and Walmart are providing pop-up clinic services, do they have are they considered a provider like the other entities listed on there, or do they have?
I would think so, right? So it's that care coordination question. You'd want to give them the medication list. You'd want them to deliver a summary back from that visit to the PCP and have part of the longitudinal record. Yes?
Just going back a little bit, I want to understand something correctly. You built a separate network for your ACO early on.
Right.
And was there a financial transaction in there to help calculate costs? Because since most of the HIEs do not have it as a use case right now, how are you handling that as a left move to that HIEs?
Right. So interesting point. As you said, in 1997 we built the NEHEN network. The NEHEN network was initially founded on administrative transactions because we wanted to do HIPAA together as a community, and it was much cheaper. We calculated the cost of payers and providers doing manual processes versus automated processes, and there was a value proposition. even though the HIE is coming to be in 2012, 2013, its focus is more clinical data and not administrative data. So I actually believe what will happen is this. So from a CSC perspective, I think the folks in Boston would agree. Administrative transaction processing and novel ways of linking payers and providers is a separate activity than the State Healthcare Information Exchange and will persist. Harvard Pilgrim will continue to dislike Surescripts. That will persist. But I suspect today what NEHEN does for Health Information Exchange clinical summary sharing may shrink over time. I mean, still may provide a front door aggregation hub and spoke model for partners or care group or children's, but the state's Healthcare Information Exchange will offer more connectivity, cheaper, faster than NEHEN can, so that's fine. You exit those businesses that don't make sense and grow those businesses that do. Our payers have actually asked us to invest substantially more in NEHEN because they believe there's much more administrative simplification that can be done through that particular network to take some of the waste out of the referral authorization process. How many of you have to ever call for approval for a CT, MRI, or PET scan? Shouldn't that be something that is automated through some type of exchange process? It may not be the highest priority for the Health Information Exchange, but for a financial exchange, it may be. Yes?
I'm Michelle Weisgraf from Community Healthcare. Question going back to trust. You said I think you have 90% of us in front patients, and you said you're educated. When I personally go to my ER and I sign something that says I give you authorization, I don't ask the question of that admissions clerk. Where's my information going? What other health partnerships? I have no idea what that means. So going forward, as meaningful use comes and there's all these other regulations put in place, what as the consumer are we going to do to really further educate them so they understand when they do opt in or out, what's happening with their information, especially with behavioral health?
So I will send you our educational materials, which you can circulate. So basically, our educational materials are not a notice of privacy practices in 9-point type that you just sign at the bottom. It's actually a portfolio of educational materials describing the risks and the benefits of sharing information, and we highlight the entities that information will be shared with and for what purpose. And you can choose not just a signature, you actually have a multiple choice test at the end where you indicate your preferences and then sign. And so with that kind of educational material, we feel we have achieved meaningful consent. Okay. Well, a wonderful discussion, and I live by email, so last slide that should you ever have any questions or issues, I have a BlackBerry or iPhone on my
We very much want to thank all of you for coming today.